this topic is actually very important. So if you can remember your biochemistry, so this is a rough graphical presentation of how the cholesterol and all the triglycerides used to digest and utilized by our body. So you can see that dietary cholesterol and triglycerides, they in combination with bile salts, they become chylomicron. Chylomicron is the almost a soluble part of these fatty acids, as they are not water soluble, so they become a combination with bile salts, and thus they form a colloidal suspension which is known as chylomicron. This is the part which further gets absorbed from our intestine. The chylomicron they absorbed and they convert into free fatty acids, which reaches various tissues, and they are synthesized to various products, including steroids, which is essential for our living. Now, apart from this, the chylomicron remnants which are not absorbed, they reach liver, and from there they form first VLDL, that is very low density lipoprotein. Then from there to into intermediate density lipoprotein, and from there LDL. Okay, and other parts has also converted to HDL, which is commonly says good lipoprotein. Okay, high content of HDL is important because they are usually get stored in liver and muscles, and moreover they are not accumulated in the blood vessels. So atherosclerosis formation is reduced by HDL. So our main target while treating a hyperlipidemic patients to decrease the level of LDL and increase the level of HDL. If we discuss about various drugs, there are mainly five categories. One is HMG-CoA reductase inhibitors, which are also known as statins. Then bile acid sequestrants known as resins, steroid absorption inhibitors, they act on various receptors to decrease the amount of steroid compounds. Then LPL or PPAR alpha activators. PPAR alpha full form is paroxysomal proliferated activator receptor alpha. They are the receptor which codes for various lipoprotein receptors. Okay, and this uh, and these receptor activators, which are also known as fibrates, they are very commonly used hypolipidemic drug. And another one is this is a new category is lipolysis and triglyceride synthesis inhibitors. Now these are the various disorders which results into dyslipidemia. It has been classified by numbers, okay, such as type 1, type 2A, 2B, 3, 4, and 5. Now depends, and this numbering has been done mainly depending on which category of disorder is there. Like in case of type 1, the main lipoprotein increase here is chylomicron. This has no problem, so the treatment is not required. In severe cases of a type 1, we only require dietary modification and behavioral changes. 2A, from 2A we need therapy, either in the form of drugs or severe lifestyle modification and dietary changes. 2A is the increased lipoprotein is LDL, 2B is VLDL and LDL, type 3 is IDL and chylomicron remnants, type 4 is VLDL, and type 5 is VLDL and chylomicron. These are various HMG-CoA reductase inhibitors, otherwise known as statins. The commonest used drug here is atorvastatin, rosuvastatin, and lovastatin. Now, if you see those drugs, they all are written in your KDT, so no issues. And apart from this, HMG-CoA reductase inhibitor, this rosuvastatin and pitavastatin, they are such a drug which has additional antioxidant property. Because of this antioxidant property, they can reduce the atherosclerotic plaques comparatively with better efficacy. Because only as they have an additional property of this, so as a result, they reduce the amount of atherosclerotic plaque. Thus, chances of cardiovascular complications become very less. Now, this is the mechanism of how this HMG-CoA works. First, acetyl-CoA plus acetoacetyl-CoA, they acted by HMG-CoA synthase, which is actually inhibited by this enzyme. So they become 3-hydroxy-3-methyl-butyryl coenzyme from the mevalonate, from their various reaction occurs, and then it converts to cholesterol. Now, statins do inhibit this HMG-CoA reductase. This is the main step, rate limiting step is, yeah, if I am not wrong. This is the rate limiting step of cholesterol metabolism. The statins inhibit this enzyme, so both these reactions are automatically inhibited. As a result, amount of cholesterol which is produced in the body is reduced. Coming to the pharmacokinetics, statins should be taken with food, so it increase absorption. Extensive fast metabolism, so bioavailability after an oral dose is only ranges between 1 to 20%. All are primarily metabolized by cytochrome P3A4 except pravastatin and rosuvastatin. And all statins are taken orally at bedtime. Reason, HMG co-reductase enzyme activity, this is most at night. Okay. So most of the statins which has a lesser duration of action or T half, they should be taken at bedtime, but exception is atorvastatin and rosuvastatin. Atorvastatin T half is around 16 hours and rosuvastatin is around 24 hours. So as a result, in any time of the whole day you can take it, but they will their action will persist till night. Okay, so that's not the issue, but conventionally all these drugs it has to be taken at night with food. Now, pharmacological action is this is the most potent. The spelling is wrong here. It's not moment. It's potent. So statins are the most potent LDL lowering agent. The reduction in cholesterol also is dose dependent. Means the higher the dose, the cholesterol reduction is more. Also reduce cholesterol synthesis by decreasing LDL content. As LDL content is less in blood, so automatically there will be increase in LDL receptors. And also simultaneously there will decrease triglyceride, IDL and VLDL content. And there is slight increase in HDL cholesterol. HDL cholesterol is mostly increased by nicotinic acid and to some extent by various fibrates. Tropic actions means the actions other than lipid lowering property is this is very good antioxidant, as we have seen that rosuvastatin and pitavastatin has additional antioxidant property. Also, few of them possess anti-inflammatory property and also anti-proliferative property as well. Uses. First line drug for type 2A, 2B disorders. 2A, 2B disorder is 2A is increase in LDL and 2B is increase in IDL and VLDL. The secondary hyperlipoproteinemia. Secondary means whether this occurs with some other diseases like hypothyroidism, then PCOD, etc. Dyslipidemia in diabetics. In diabetic patients also because of insulin deficiency, there's high chance of development of dyslipidemia. And also pravastatin is such a drug which is approved for children more than 8 years. In case of if there is any genetic conditions like known as heterozygous familial hypercholesterolemia. Adverse effects. The commonest adverse effects which is seen is in muscle ache, rise in CPK means creatine phosphokinase, myopathy, and rarely rhabdomyolysis can occur. The muscle side effects are the commonest, but among them rhabdomyolysis, which is the deadliest side effect, but luckily it occurs very rarely. Then rise in hepatic transaminase, GIT upset, and headache. Now, the there is a very important thing to notice is that liver transaminase and creatine phosphokinase they should be regularly checked just to miss to notice whether there is any development of rhabdomyolysis or muscle disorder, and as well that it has some problem in hepatic transaminases. So it's very important to regularly monitor this level, so that any early adverse effect occurrence can be noted. This is another group known as resins. The classification here is bile acid sequestrants. They react with bile. They form insoluble components with bile salts by reacting with it. So as a result, the formation of chylomicron is reduced. So obviously, fat absorption is reduced from GAT. Drugs which are used are cholestyramine, cholestyramine, and cholesevelam. They are basic ion exchange resins. Means they has a cross reaction between various basic ions which is in the bile. They are neither digested nor absorbed. So by binding to bile acids, they basically reduce the amount of cholesterol which is absorbed from GIT, and usually they get excreted from by feces. Both bile salts and and cholesterol get absorbed. So as a result, there is less amount of cholesterol absorption. So obviously, there will be reflex increase in LDL receptors. What are the areas? As you have seen from the previous slide that they usually get excreted through feces in the form of cholesterol and bile salts. So the commonest adverse effect here is flatulence. Flatulence occurs because there is a more amount of fat in the stool, so stool formation is hampered. Apart from this, there is heartburn, dyspepsia, and other GIT complaints like nausea, vomiting, etc., which is the commonest side effect of with lots of drugs. They interfere with absorption of fats or fat-soluble vitamins and drugs, such as warfarin and other statins. So as a result of there is a less amount of absorption of fat-soluble vitamins, so vitamin deficiency can occur. So what are the fat-soluble vitamins? Anyone can say? What are the fat-soluble vitamins? Vitamin K also they has another function. They helps in the synthesis of various clotting factors. So hyperprothrombinemia can occur as a deficiency of vitamin K. So to inhibit this, we should administer other medications like statins and warfarins, various vitamin supplementation. They either need to be administered at least 1 hour before or 4 hours after the resins administration. And regarding this matter, if any other the drugs need to be administered, the preferred resin of choice is cholesevelam because they usually terminate their action within 2 to 3 hours. So this protocol can be followed very easily. There is the contraindication. One is complete biliary obstruction. So if there is complete biliary obstruction, ultimately what will happen that bile salts is not going to reach the intestine. So as a result, there is no use of using this category of drugs. Then if there is chronic constipation, because the drugs which is given, they used to administer bile and cholesterol, which is ultimately get excreted through feces. If there is constipation, the excretory procedure will be hampered, so there will be more GIT related problems. And if there is severe hypertriglyceridemia, means if the triglyceride level is more than 400 milligram per day, in this scenario also the drug is not going to work because the patient already has developed some other metabolic problem. This is the most important group, fibric acid derivatives, or otherwise known as fibrates. They are they act through by proliferation of one receptor known as PPAR alpha. Drugs which here use is clofibrate, gemfibrozil, bezafibrate, and fenofibrate. The commonest drug here which is used in combination with statins is fenofibrate. And gemfibrozil is such a drug you should remember that it should not be combined with any other group of drugs because there will be more amount of development of rhabdomyolysis. They work. They activate nuclear receptor PPAR alpha. So as a result, the nuclear receptor, they codes for synthesis of various lipoprotein receptors and lipase enzymes. So there will be increased amount of fatty acid oxidation. Pharmacology action is the commonest thing is that they reduce triglyceride either by increased degradation or by decreased synthesis. LDL receptor increases and there is moderate rise in HDL and they promote fibrinolysis. So fibrinolysis is the most commonly promoted by gemfibrozil. So as a result, in case of any MI patients, gemfibrozil sometimes may get beneficiary because fibrinolysis is a very important procedure of prophylactic method in case of MI. Where it is used in type 3 and type 4 hypertriglyceridemia. We can use in type 2B type 2B hypolipidemia with other drugs, commonly with statins. Increased triglyceride and decreased HDL cholesterol in metabolic syndrome if it occurs in case of type 2 type 2 diabetes mellitus. In these three conditions, fibrates are most commonly used, but nowadays fibrates in combination with statins is the commonest used drugs in case of any dyslipidemia. Adverse effects. GI almost all are similar like various statins. So the commonest thing here is that there is GI upset, eosinophilia and rash, headache, blurred vision, impotence, myopathy, cholelithiasis. Myopathy is most commonly evident with gemfibrozil, and myopathy also is seen with statins, as I already has discussed. So gemfibrozil and statins should not be combined. In case of any patient who has previous history of development of rhabdomyolysis, no fibrates is to be combined with statin. Contraindications are impaired renal function, which will result in more amount of adverse reactions. In case of pregnant or nursing women, because reaction against pediatric patient data is not sufficient, and as there is a severe risk of muscle degeneration and lysis, so that may result in severe symptoms in case of children, as their muscle and various skeletal structure is not formed properly, and if there is any pre-existing gallbladder disease, because it has a side effect known as cholelithiasis. Yes, nicotinic acid. Nicotinic acid is a vitamin B group of chemical. So it results in adipose tissue, which is the basic lipid storing cell in our body. There, niacin binds to a GI protein coupled receptor, resulting in decreased intracellular cyclic AMP. So as a result, they will inhibit lipolysis. Drugs will be stored, and there is decreased hepatic VLDL production and also decreased IDL and LDL concentration. The problem is that they require in very high dose, starting from 200 milligram thrice daily. Usually the dose reach up to 2 to 4 gram per day dose. And also as there is a high dose is required, so obviously side effects also will be more. This is the most effective drug to raise HDL cholesterol, and there is rapid reduction of triglyceride and LDL, and decrease lipoprotein A and fibrinogen. So as I said before, that this nicotinic acid, they raises our HDL cholesterol, which is known as good lipoprotein, to be the most. But also it has its own side effects that matters that also contradicts its use. That's why this drug is not very commonly used nowadays. What are the adverse effects? Commonest thing is flushing and pruritus, which is otherwise known as niacin flush. Now, why this occurs? As from the name, it is very evident that this mainly acts on the nicotinic type of cholinergic receptors. So, there is a dilatation of the various peripheral and cutaneous vessels. So, and also the drug requires in a very high dose. So, flushing and pruritus is very common in this symptom. And this also occurs due to stimulation of prostaglandin D2. Okay, so in this commonly occurs with either sustained release or extended release formulation. Prevented by low dose aspirin 325 milligram half an hourly before niacin, which reduces prostaglandin formation. So this symptom can be reduced. Lanopapran, which is a specific anti-flushing drugs, can be used in those patients who develop severe symptoms of flushing and pruritus. Apart from this, there is development of dyspepsia, vomiting, and diarrhea, aggravation of PU, dryness and hyperpigmentation, liver dysfunction and jaundice, Hyperglycemia, diabetes mellitus, hyperuricemia, and gout, they are usually happen with this drug. It interacts with antihypertensive, resulting in postural hypotension, and with statins, they can also cause myopathy. Where they use. They are a wide spectrum hypolipidemic agent. As you have seen that this is the most effective drug causing increased HDL cholesterol, and also with the lipid LDL and VLDL lowering property is also good. So almost all the spectrum of hyperlipidemia, this drug can be used. Hypertriglyceridemia type 3, 4, and 5, this is the drug of choice. Adjunct to statins or fibrates in case there is no contraindication to combinations such as renal failure, hepatic problem, etc. And also they can be used to control pancreatitis associated with type 4 and type 5 disorders. This is a new category of drug, sterol absorption inhibitor. The drug which is available in market is ezetimibe. They impairs dietary and biliary cholesterol absorption at the brush border of intestine without affecting fat-soluble vitamins. In the villi, there is a cell known as brush border cells. So they are the main cells which involves fat absorption. So they act directly on those cells, those cells which results in decreased amount of dietary and biliary cholesterol absorption. But the plus point is that as they has no effect towards fat soluble vitamins. So obviously there will be compensatory increase in hepatic cholesterol synthesis, and with the hepatic cholesterol synthesis, so with that to reduce this cholesterol synthesis, we have to use statins. Ezetimibe is never used as a single drug. It will always need to be combined with various statins because to reduce this hepatic cholesterol synthesis. The simple reaction is that as there is decreased amount of biliary cholesterol absorption, so there will be reflex increase in hepatic cholesterol synthesis. This reaction is inhibited by statins. And also reversible hepatic dysfunction and myositis can occur. In case of this occurs, that can be very easily evident by checking various hepatic transaminase enzymes and checking of creatine phosphokinase, which are marker of hepatic dysfunction and myositis. So when this develops, if early noted, the drug can be stopped, and this is the problem which occurs is usually reversible. The guidelines. This is National Cholesterol Education Program. They usually this program they encodes for various therapy, and regularly they updates treatment protocol. So according to this program, statins are prescribed. They have guidelines for that. So statins are prescribed after acute coronary event irrespective of lipid level. Then lifestyle modification like exercise, cessation of smoking and alcoholism, then less amount of fat content in food, and then also increase amount of fibers with diet. But statins are always prescribed after an acute coronary event, whatever be the lipid level. When to use drugs? To decide when to use drugs, we should monitor various lipid level parameters like HDL, LDL, VLDL, IDL, etc. Coronary artery disease, diabetes mellitus, and peripheral vascular disease. They all are the indication of hypolipidemic drugs. Now this is optimal levels. We have seen, I've shown you that the total cholesterol level, LDL cholesterol, HDL cholesterol, and triglycerides. The optimal level here is total cholesterol is 200, LDL cholesterol is either less than 100. In case of a history of cardiac coronary artery disease, the level should be less than 70. HDL cholesterol in case of men more than 40, in case of women it's more than 50, and triglycerides should be less than 150. Borderline high is this level. If it is high, more than that, and very high if LDL cholesterol is more than 190, and if triglyceride value is more than 500. This is very high, and this symptom need to be treated very aggravated. A treatment based on LDL cholesterol. If LDL cholesterol is more than 190, means if it is 190 means very high, we should start statin. If history of CAD, all should receive drug therapy, irrespective of whatever be lipid level. Target LDL cholesterol level is less than 70, and if inadequate response means we have to check various lipid the lipid profile at every 6 weeks, and those need to be doubled in every 6 week interval. And if this also doesn't occur, we should add a second line drug. And usually in case of any dyslipidemic patients, nowadays the common protocol is to use a statin with a fibrates, except gemfibrozil. Treatment of low HDL cholesterol. The target total is we determine by cholesterol HDL cholesterol ratio. The target is here to make it less than 3.5. And to increase HDL cholesterol, the most effective drug here is nicotinic acid. Later, the next effective drug here is fibrates and statins. And as fibrates and statins, they are indicated in other cases of dyslipidemia also. So usually this combination is given either singly or with two of these drugs. Nicotinic acid, the problem here is it has a high amount of side effects, and also very high doses required in frequently level. Compared to this fibrates and statins, they are only once daily doses enough. So patient compliance is good in for these drugs. In case of triglyceride is raised, the target here is 150 milligram per deciliter. First thing is to treat the cause. If there is primary, so we can't treat the cause, we have to treat it symptomatically. But if it is secondary hypertriglyceridemia like diabetes, then hormonal problems, hypothyroidism, so first those causes need to be treated. Usually in cases of secondary hypertriglyceridemia, if we treat the proper cause, usually the treatment gets normal. Then lifestyle modification, you can use statin and specific triglyceride lowering drugs like fibrates and nicotinic acid. If triglyceride level is more than 500 means which is very severe, so we need vigorous treatment. Now this is an in short treatment protocol for various types of disorder. So type 1, I've already said that this is increase in the chylomicron, so no treatment is required. 2A and 2B drug of choice here is statins, and apart from this in 2B we also can use fibrates and nicotinic acid. Type 3 fibrates is the drug of choice. Type 4, which is increase in VLDL, fibrates and nicotinic acid are the drug of choice. And type 5, nothing is required. So this is your homework. Something I have not included. I have not included various drug interaction with drugs. Something need to be kept for you too. The first thing is that you have to read treatment protocol for the various cardiovascular effects of increase in various triglyceride and lipoprotein levels. Various drug interaction between statins and fibrates, then statins, fibrates, and other agents like various cardiovascular drugs, then hormonal agents. Okay, because this is a very important drug interaction, not only for your pharmacology exam, also in your during your clinical practice as well. The comparison between different groups in respect of their potency, side effects, and at which aspect of lipoprotein alternation it is required. Okay, so these are topics here. Please